So thankfully, pancreatic neuroendocrine tumors is one of the tumors that I would believe have more therapies that have been brought to our armamentarium in the last decade than in any other tumor. We now have hormonal therapy, including lanreotide, which is recently FDA approved, as well as sandostatin or octreotide. We have targeted therapies, such as sunitinib and everolimus, which are FDA approved for pancreatic neuroendocrine tumors that are progressive. We have cytotoxic therapies, which are oral, such as temozolomide-based therapies. And then we have IV treatments as well, including platinum-based treatments. So where do we put them all into the paradigm and in what order? That can be challenging. So we often consider lots of different factors to consider which therapy should be used and how. So in general, in patients that have small volume asymptomatic disease that may be starting to grow, we opt to traditionally try the hormonal therapy with lanreotide or octreotide first. Why? Because it's very well tolerated. And there are two pivotal studies that were done that show that the somatostatin analog therapy, this hormonal therapy, will slow down the rate of disease progression. So the clarinet study, for example, proved in pancreatic as well as other GI neuroendocrine tumors that it could slow down the rate of tumor progression. Interestingly, the placebo arm had, for pancreatic neuroendocrine tumors, had a 12-month PFS, whereas the patients on lanreotide at 2 years hasn't even been met. So the great news is it unquestionably has proven that hormonal therapy using somatostatin analogs can unquestionably slow down the rate of tumor progression. But if you look at the placebo arm, again, it shows that it took the tumor a year to grow with just placebo. So sometimes there are patients that we can really watch just with observation alone because every therapy has some side effects. And that allows us to, again, better say, I'm not going to let them come back in a year, but some of my patients I could follow in the first 3 to 4 months, see did the scan show any changes, and often it doesn't, and then follow them before we actually start therapy. Targeted therapies with sunitinib and everolimus are also considered for patients with progressive disease that tend to have lower volume disease. Both of the studies, both the RADIANT-3 for everolimus and the sunitinib study, were both published in the New England Journal of Medicine. Both proved that, again, both targeted therapies could slow down the rate of disease progression. So both of them, on average, had a progression-free survival of about 11.5 months versus the placebo arm of about 5 months. So no one's ever compared sunitinib to everolimus, but the results of these two very well-conducted randomized phase 3 trials suggest that they're both efficacious in slowing down the rate of disease growth. The response rates, however, were not very high. And so we tend to use those therapies in patients that have lower volume disease, although it's certainly appropriate to consider for patients with higher burden disease as well. But typically in patients that have symptomatic high burden of disease, we often consider cytotoxic therapies, traditionally temozolomide-based therapies, because we know that the response rates could be greater. Now, having said that, we don't have great level 1 data for temozolomide-based treatments. There is an ECOG trial right now being conducted by Dr. Kuntz that we're participating in it, to ask the question of the role of Temodar plus Xeloda versus temozolomide alone. But that's a randomized phase 2. So we don't have level 1 phase 3 data for temozolomide-based treatments, but we know that our clinical experience has suggested that it really does cause a nice tumor shrinkage. So in patients with heavy burden of disease, we'll often try cytotoxic therapies first.
I can't even read my notes. Next to the treatment of liver metastases. Now I can.
So for the treatment of liver metastases, we often consider regional-based therapies such as surgery or embolization. And there are several types of embolizations that one can consider. There's radioembolization using radio-labeled spheres, yttrium-90 spheres. There's chemoembolization where you can use chemotherapy in addition to bland embolization. There are no prospective randomized trials to tell us which one is better. So it really tends to be institutional-based. So the take-home message is wherever you get your embolization, whether it's radioembolization, chemoembolization, or bland embolization, you want to ensure that that interventional radiologist is very comfortable with that particular type of technique, because it certainly requires expertise for each one. The radioembolization is done on an outpatient, so that's nice for patients. But the caution there is that we truly don't know yet the very long-term toxicity of radioembolization, particularly the radiation to the liver. And that's important for our patient, again, that may live, hopefully, for many years. So we want to ensure that the long-term toxicities are also quite low. In contrary, the bland embolization, for example, can be very hard on the patient in the short term. It requires hospitalization because they often result in what's called post-embolization syndrome, nausea, fatigue, pain, fever sometimes, because we're literally blocking off the blood supply to these tumors, but you get a very nice response, but the patients can have some short-term toxicities. Long-term, however, that's a very safe modality that's been done for a couple of decades. So we feel very comfortable not only doing it, but actually repeating that without necessarily compromising the liver long-term. So it's that balance. So interventional radiologists will very often tell the patient and advise them on the best method of regional approach for that treatment. Surgery, again, is often not curative when the cancer has spread to the liver, so we have to be very careful in the risk of that in patients that are otherwise asymptomatic.